All right, everyone. Happy Monday. It's time for another Archer Review webinar. And if we haven't met, my name is Brittany, and I'm a family nurse practitioner. And today we are going to be covering a very important topic that you will see every day when working in primary care, or quite frankly, any other place that you're working, and that is anxiety and depression. And this is such an important topic and one that is kind of nerve-wracking. I remember when I was getting started into practice, this one kind of intimidated me a little bit because, I wasn't a psych nurse. So before I went to nurse practitioner school, I wasn't a psych NP during my training. So this is just something that it's just kind of something that you kind of learn, and it's better to learn it before you go get started in the profession than learn it on the fly. So this is just something I thought would be really good to go through today. Hiva is in the comments today, so in the chats. So again, as always, we love interaction. We love to talk to you while we're going through these webinars, kind of thinking about what you're thinking about and kind of your thought process so we can make sure that you're headed in the right direction. So again, if you have any questions, if you have anything as we go along, please just let us know and let us know how we can help you. So let's go ahead and get started. So let's talk about the DSM-5, as you'll hear it called in practice, and that is the Diagnostic and Statistical Manual of Mental Disorders. And this is the 5th edition that we're currently using, and again, commonly referred to as the DSM-5. This is a comprehensive classification system and diagnostic tool that many providers, including psychiatrists, psychologists, and of course, healthcare providers use. This is published by the American Psychiatric Association and provides the criteria for a myriad of various mental health disorders, mood disorders, psychotic disorders, and other things. And this outlines specific symptoms and criteria that must be met for each disorder to be diagnosed, and it helps us, including nurse practitioners, in assessing and diagnosing mental health conditions. So again, I have a copy of this on my desk, and this is something that you might want to look at and think about purchasing for yourself, and at least knowing where to turn to when you have these particular challenges that you're faced with. All right, we're going to talk about screening tools. At physicals, it's a good time to screen your patients. If they're on antidepressants or other mental health medications and they're coming in for their routine, blood pressure rechecks or whatever, this is a good time to just kind of ask them how they're doing on their medicine regimen, make sure that they're doing well. Even if they see psych in your primary care or maybe your urgent care, just making sure that they're doing all right on their medications, and do you need to help them move that appointment up for their specialist or whatever it be. So this is just a really good time to kind of just check in with your patients every time you see them, and at least once a year. And again, the physical is a really great time to do that. So even if you don't suspect a mental health disorder, screening is going to be really important because as nurse practitioners, right, we're very screening and prevention based, right? So it's appropriate to try to screen patients regardless of the setting that you're in. And again, we want to provide that holistic care. So, mental health is going to be part of providing that. We want to make sure that they're well in all facets. Several screening tools here. I have them listed. And again, when we evaluate these against the DSM-5, it helps us to make a proper diagnosis. So these are Beck Depression Inventory, the Geriatric Depression Scale, the Generalized Anxiety Disorder 7, or the GAD-7, and the PHQ-9, which by far is the one that we use all the time, Patient Health Questionnaire. So let's just take a quick peek at what all is included on each of your screenings. So Beck Depression Inventory is a self-report assessment designed to measure the severity of depression and symptoms in individuals over the age of 13. Consists of 21 questions. Each item is scored 0 to 3. And remember, a higher score on this suggests more severe symptoms. Some of the questions are focused upon things like mood, pessimism, sense of failure, self-dissatisfaction, guilt and self-dislike, suicidal thoughts, agitation, loss of interest, So again, very comprehensive inventory. And if you work in a psychiatric setting, you may probably see this even more than in primary care. We also have the geriatric depression scale, again, good for our older patients, assesses for depression in this population. There's a 15 yes or no questions, a little bit easier for them than trying to rate sometimes, related to symptoms commonly experienced by older adults with, again, depression, mood, energy, appetite, and sleep. And just as a caveat here, sometimes they will score higher on these depression scales, but you'll kind of take a look and dive in a little bit and be like, oh, you know what? They're just not sleeping, or they're just not eating, or, they're just lonely. And so, trying to get to the root of the cause of, what's making them score high on these scales can kind of help direct our conversations and, some of our treatment plans for these patients. So, this is really used in primary care as well, and also geriatric settings whenever you are identifying symptoms in older adults. And again, that magic number there is a 5 or more. It's suggestive of depression. We're going to need a little bit more digging. Again, you have the generalized anxiety disorder, 7, GAD-7. We use this a lot. Remember, anxiety and depression often hold hands. And this is also a self-administered questionnaire used to screen for generalized anxiety disorder and assess the severity of anxiety symptoms. It has 7 questions on there that inquire about common anxiety symptoms, such as excessive worry, restlessness, difficulty relaxing. And again, that patient's going to scale it on 0 to 3. Scale of up to 21 here. As you can see your numbers, it kind of gives you a mild, moderate, and severe. And this is really just pretty straightforward, screening tool. The patient health questionnaire. This is one, again, that even Medicare wellness patients, they often will require us to do this at their annual physicals. This is listed on there. It also talks about minimal all the way to severe depression. There are 9 questions, including a suicidal thought question down here at the bottom. So if you're kind of glancing over that, make sure you're checking out question 9. And these questions inquire again about these depressive symptoms. You can administer this in PHQ-2 form, which are the first 2 questions. It talks about things like loss of pleasure. And if they start scoring up in here in the 1s, 2s, and 3s on those first couple of questions, then go ahead and administer the whole thing. And again, these higher scores, definitely bring up those red flags, things that we need to be talking to our patients a little bit more about. All right, suicidal warning signs. Of course, anyone with a history of or active depression, we need to always assess for suicide risk. I know that most of us are very familiar with that Columbia Suicide Severity Rating Scale, and I want you guys to put in the chats, even if you're a nurse right now, I want you to be putting in the chats, what are those top 2 or 3 questions that we ask patients, if maybe they popped up positive, like a 1 or a 2, maybe even a 3 on that PHQ-9, thinking about suicidal thoughts or harming themselves. I put it here for you for a hint, but I want you to be thinking about that fancy word plan, or that little word plan, should I say, and what kind of questions are we going to be asking the patients? So if you are putting in things like, do you have plans? Have you thought about hurting yourself or someone else? And then also, how lethal is their plan? That's another one that I think about too. And then, have you thought about how you might carry out their plan? And of course, there's other things too, like giving away possessions, or maybe they are stopping taking their medication, things like that, again, that can kind of clue you in and thinking about this. And of course, anytime someone, starts talking about plans with plans to carry them out and their plans are lethal, then you need to go ahead and be planning to put this patient to the ER instead of letting them go home outside of your clinic. So something that these patients definitely need quick intervention. All right, so let's talk about depression first, and this can affect individuals of all ages, genders, backgrounds. It may be triggered by various factors, including genetic predisposition, biochemical imbalances in the brain. Think about postpartum. That's a really important time. It can go all the way up to 18 months. I didn't know that until just, when I was in school. I had always heard about postpartum depression, but didn't realize it could last up to 18 months. Life stressors, trauma, chronic medical conditions. And so that's why it's so important for screening these patients, looking for the signs of depression every time we interact with a patient, because circumstances can change, right? Everybody can be doing really well, and then they have some sort of life event, and it kind of triggers that depression. So just again, an overview: can hold hands with anxiety, affects everyone, and the screening is our top priority. So the exact pathology of depression obviously is not fully understood, but it is very complex. Lots of interactions between genetic, biological, environmental, and psychosocial and psychological factors. You could also have those imbalances. We think about our feel-good neurotransmitters here: serotonin, norepinephrine, and dopamine. And also they can have these changes in their brain as well. And, structural, functional changes. Think about your stroke patients. Think about those who have chronic conditions. These have been observed in, these changes either before or after the diagnosis of depression can often be assessed as well. So again, a very complex, very not well understood condition, but again, can have lasting impacts on these patients. So symptoms of depression can vary widely. It's different for everybody, but mainly they include persistent feelings of sadness, emptiness or hopelessness, loss of interest or pleasure, which has that fancy word of anhedonia, changes in appetite or weight, sleep issues, fatigue, difficulty concentrating or making decisions, excessive guilt, shame, and then, of course, thoughts of death or suicide. And some of those physical signs that we can see here and assess for and help to treat, are really important. Again, we're thinking about mental and physical care of a patient with depression. So can really be complex, and these patients can get complex very quickly. And again, we always want these patients to be upfront with us if they're having any bad thoughts about harming themselves or others, or if they have plans. All right, so our workup here, it goes beyond our screening forms and the patient history and interviewing, and we want to rule out any organic causes of depression. So think about, if their vitamin D or B is low, they may have lack of energy, or they may have a thyroid imbalance that could cause or exacerbate depression, or cause symptoms like depression or anxiety, should I say. It won't cause depression. And, really just try to rule those things out, making sure, before I want to ever stamp depression on someone's chart, I want to kind of do more of a workup, get their labs, do a full physical exam, make sure that we're not missing anything that can kind of present itself, right? Because lots of different things, these symptoms can be vague, and they could be having pain or not sleeping well, or, getting up in the night to pee, and that's causing their sleeping problems. And then here we've stamped depression on their chart when really, they just have some other issue going on. And of course, for treatment, I definitely will say it's a multifaceted approach. I don't like to have patients just, well, I take a pill for my depression. Well, that's great. And, sometimes medications are warranted, but also talking about the non-pharmacological options. Cognitive behavioral therapy has been shown. We have lots of research on that. Also, lifestyle modifications. We have a lot of research on exercise, making sure that these patients are getting adequate sleep. They're reducing their stress in their life. So, really working together to come up with a plan to combat this depression. And of course, close follow-up whenever we're starting to prescribe, especially the medications, but any treatment plan for depression, we're going to have close follow-up, 2, 4, 6 weeks out at the most. And again, have them to call us back and go straight to the emergency room if they're starting to have suicidal thoughts, because remember that some of these medications have that black box warning for those thoughts. So just, giving them warnings of what to expect and look out for, and signs and symptoms to report. All right, so this is our first line medication class that I like to group together because they're so similar, and these are the selective serotonin reuptake inhibitors. So I always tell patients, they go down to your gut and get the good, feel good, neurotransmitters, dopamine, and serotonin, bring it back up to your brain, and it helps with that serotonin. Again, it's in the name. And it keeps it more available in the brain, and it improves the mood. It alleviates the symptoms of depression and anxiety over time. So who can tell me in the chats what about how long it takes for an SSRI to kind of get going in the body? I want you all to think about that. Is this like they take one pill and they're feeling better, or take 2 or 3 pills and they're feeling better? I want y'all to put in the chats how long it takes for an SSRI to really reach that therapeutic level. Again, these are first choice for us, and these are going to take about 4 to 6 weeks to reach peak effectiveness. And again, we're going to do that trial starting dose and follow up within a couple of weeks. So when we're getting started on that. And so again, the patient's not going to feel better after 1 or 2 pills of this. This is going to take them a while to get this in their system and really get going on this medication. And so, also after that, first week or two, if they're doing well on it, not having a lot of side effects, we can consider an titration up in their dosing and seeing. But if they're having the side effects, we of course want to know right away. We might choose to discontinue it instead of going up, and making sure that we've got them on the right thing. And the one thing about this is that it's kind of a good thing, kind of not a good thing, is that everybody reacts a little bit differently because there's several different SSRIs out there. And so if one doesn't work, then we can switch to another. And the good news is that we haven't lost all that ground we've gained. We can kind of switch between within that drug class, switch between 2 or 3 different things if things are causing problems. So maybe they've started out on a little dose of Zoloft and it's just not working, or they're having side effects or whatever. We can just switch them right over to Lexapro. That's just an example. And so that is the nice thing about the SSRI. So just because one doesn't work doesn't mean that others won't. All right. So again, thinking about side effects, the big ones that patients report are GI side effects, especially when first starting these. Weight gain, of course, decreased libido, which of course depression can cause as well. And then all these SSRIs have a black box warning. So again, thinking about screening for and telling them what to expect for increased suicidal ideation, especially in younger people. So we really need to review this with these patients, make a plan with them to seek immediate help, and just bypass my office and go right on to the emergency care if they are going to start having those suicidal or homicidal thoughts. Also, another thing I just want to point out here, if patients are taking MAOIs, which is another drug class of psychiatric, specifically antidepressants, they can have a risk of serotonin syndrome. And again, remember, this is a potentially life-threatening condition. It needs emergent care. Patients with a history of bipolar disorder might need additional mood stabilizers along SSRIs to help prevent the mania. You guys have probably remembered that from school. We're not going to get into bipolar today, but it is something that, be thinking about. You can't just treat it with an antidepressant. This is specifically for depression. So let's take a look at some of our commonly prescribed SSRIs. And again, remember, they don't have all the same endings, but a lot of them will end in that oxetine or allopurinol. So you can see here, I've got them listed for you, and they're, some of the endings are kind of the same. So also we have SNRIs that we're going to get into here in a minute. And so those often end in oxetine as well. So just some names for you, nothing to memorize. It's just, so you can get familiar with the names. All right, again, we've talked about serotonin syndrome. It's a critical condition that warrants our attention. Again, probably going to be sent to the ER, and then serotonin, has gotten too much in the brain at that point. And some of the things that these patients, if they're using multiple, medications for their mental health, they're on higher doses of antidepressants, they're on migraine meds, or also St. John's wort. So I actually advise my patients to not take St. John's wort if they're taking an antidepressant. And then some of the common symptoms you can see is, rapid changes after that med adjustment. So again, if they're not feeling well after they've changed their medication dosing or their medication regimen, they need to let us know. They can be confused, agitated, increased heart rate, sweating. And again, this is a medical emergency, and you're going to remove that medication from their regimen. And they're going to be monitored in the hospital. All right, SNRIs, I'm going to just touch on a few of these commonly prescribed one, Effexor, Cymbalta, and Pristiq. And again, these are going to increase availability of serotonin in the brain, but also norepinephrine, and patients can feel like more focused. And remember that norepinephrine can be a little bit of backfire for them because it's excitatory, right? And it can have patients to like feel panicky, so this may not be a great choice if your patient already is kind of prone to anxiety. And again, with most psych meds, we need to take that thorough patient history and prescribe them the best fitting medication for their symptoms. Also, patients with high blood pressure, we try to avoid the SNRIs if we can because it can cause hypertension. So always something to think about for the patient and their information. So just talk to your patients and kind of just try to help them come up with the best medication for them. There's another large group of antidepressants called atypical antidepressants, work a little bit differently. They can be used alone, but more commonly are used in conjunction with other antidepressants. Two of these common ones you will hear and see, bupropion or Wellbutrin, trazodone, and Deseril. And one other thing I will say too is sometimes you'll see trazodone used for like sleep, and we're trying to kind of get away from that. So just a little side note on trazodone. But again, these are antidepressants and can be used in conjunction with other antidepressants as well. TCAs, that's our tricyclic antidepressants. Again, just another medication class for antidepressants. Again, lots of different things. SSRI is still going to be your first line, but I want to touch on every single drug class there is of antidepressants. Again, not considered first line treatment for depression, but it may be something that we consider if these patients are not responsive to SSRIs or SNRIs. But we do see them used frequently. And also thinking about your patients who have chronic pain. So these patients can kind of use some of these TCAs for that because they do they do block the reuptake of norepinephrine and some serotonin as well. And they also have anticholinergic side effects. So again, just some things that we need to be paying attention to. And again, not first line usually, but they can be used in the right circumstance. You know, if you have a patient that has a lot of incontinence, maybe you do want that anticholinergic effect. So again, think about that. And they have a larger potential for overdose. That's another little side note here compared to the other antidepressants. And we would, again, avoid them for patients with that suicidal ideation history in their background, or, you know, if they've ever had like an attempted suicide, then again, we probably want to stay away from the TCAs. All right, these are some side effects of the TCAs. We have them literally listed out for you. I'm not going to take time to read all of them, but they're here. Just be aware of them. Again, if you're prescribing these, really paying attention to what you are telling your patient to look out for. All right, MAOIs, again, I'm just going to briefly touch on this, is monoamine oxidase inhibitors, again, commonly called MAOIs. These are one that are pretty rarely used, I'll be honest, unless you're a psych NP. Probably not going to be prescribing this a whole lot in primary care, but sometimes you will see patients coming in on them, so I want you to be aware of them. And they work by inhibiting the enzyme monoamine oxidase, which breaks down those neurotransmitters such as serotonin and dopamine in the brain. And by inhibiting this enzyme, these increase the levels of those neurotransmitters and lead to an improvement in mood and alleviation of these depressive symptoms. And of course, the biggest side effect we see are those anticholinergic side effects. And remember those fun little mnemonics that you might have remembered from NCLEX. That's where I learned this is patient can't see, can't pee, can't spit. And or you can say can't pee or poop, whatever, and whatever word you want to use there to remember MAOIs and anticholinergic effects. But again, these also interact with foods. So there's dietary restrictions with this. Do you guys remember some of those tyramine rich foods? You guys can put those in the chats and I'll come back and touch on them. And these also interact with drugs like SSRIs, TCAs, and then also medications like Imitrex. So, you know, really paying attention there. with your MAOIs because they have a lot of drug interactions. And the food interactions, you guys got it. So things like aged cheeses, cured meats, soy products, alcohol, and even some vegetables like spinach. And if these patients are taking this, again, they're going to have dietary restrictions, and there's going to be a huge education piece with these patients if they're taking MAOIs. All right, just a few other little couple meds that I just want to talk about here that I've added in for you. Adjunctive therapy for antidepressants. We've seen a couple of them come out on the market, mixed reviews, but Vraylar can be used by itself as a standalone for major depressive disorder. Just recently got approved for that, but also we're seeing it added on as a adjunctive therapy to SNRIs, SSRIs, or Wellbutrin. Often the side effects again here, GI upset, tremors, or unwanted movements, and then suicidal ideations. Again, has a black box warning, as all these medications do. There is also an indication for bipolar. So again, Vraylar has a really good, profile to it, but it's just something that you definitely want to titrate and go slow on this one, and really close monitor your patient if they're on Vraylar. Rexulti is another adjunctive therapy that you can add on. And again, they've kind of advertised this one as, in addition to the antidepressant, don't lose what you have gained already, but it's just not working all the way. And I kind of call this my booster. And so, maybe they're on like 15 or 20 milligrams of Lexapro, for example, and it's helped them some, but it's not 100%. This might be one that you want to add on to the 2 milligrams of Rexulti. And again, this isn't really used alone. I haven't seen it used alone, but weight gain, GI upset, increased cholesterol, and of course, as always, this should be stamped on every single one of these slides. Caution in elderly patients, 65 and above, because these a lot of these are on your Beers criteria. So again, doesn't mean you can't prescribe it. It just means you really need to monitor these patients. All right, so again, just a summary for you. SSRIs, here's your endings. Risk for serotonin syndrome, of course. Suicide precautions in the first couple of weeks. TCAs, side effects are your TCAs here: tachycardia, cardiac effects, anticholinergic effects, or sedation or sexual dysfunction. Cardiotoxicity can be lethal, so again, not first line in primary care. MAOIs, definitely not first line in primary care, but again, tyramine-rich foods, I've got your picture here for you, and may also cause a hypertensive crisis. Again, if I'm starting to get into in primary care, the SSRIs aren't working too well, or, maybe I've given them a little booster and it's not doing what I want them to do, at that point, I'm kind of thinking about maybe I do want to send them to psych. If they're on multiple medications for mental health, again, might be considering sending them to psych. So remember, in primary care, it's important to know where we end and specialty begins. All right, let's just touch on anxiety for a few minutes. I have a little pop quiz coming up for y'all here at the end. That's going to be a good time, so I want to save time for that. Again, this often holds hands with depression. We treat this in primary care all the time and really in every setting. And so recognizing the symptoms and knowing the basic treatment is going to be really important. Of course, referring out to our colleagues if this is, out of hand. But again, wait times can be long, and specialists don't always take insurance, so there's barriers to care here, and so that's why I want you all to be familiar with this so that you can kind of get them started in the right direction. Anxiety, like we said, is a common mental health condition characterized by persistent feelings of worry, fear, or unease. And this can interfere with their daily activities and quality of life. And it's essential for us to understand anxiety comprehensively, including pathophysiology, symptoms, and diagnostic workups, and provide safe and effective care for these patients. Oftentimes, anxiety disorders, again, are very complex. They interplay with genetic, environmental, and neurobiological factors. Of course, you have those serotonin neurotransmitters such as norepinephrine, and then you also have GABA. These all play critical roles in regulating mood, anxiety, or relaxation. And anytime we have dysregulation can cause lots of alterations in the brain circulatory system. So persistent worry or apprehension, restlessness, feeling on edge, fatigue, difficulty concentrating, sleep disturbances. So you can see there's a lot of overlap here with depressive symptoms that these patients will often have. And again, it can be cyclic for these patients. And we always, of course, before we just send anxiety on a patient's chart, want to be doing the same thing as depression, and that is proper screening, proper assessment, a little bit of workup, and making sure, because again, these manifestations here can be a lot of different things, right? You know, tachycardia. I mean, we sure don't want to miss something cardiac there, shortness of breath, same, you know, GI distress. So again, these things here, you know, we need to make sure that we're kind of working them out and seeing them through before we just start talking about anxiety. Again, once we've ruled out other causes of our symptoms for our patients, we can kind of begin our anxiety workup. Start with open and ended questions, investigate any physical symptoms the patients may have. You're going to do your GAD-7 screening tool that we talked about in the beginning. And again, of course, ruling out any thyroid or cardiac origins, right? So some of these patients, you know, if they have that impending doom, we, you know, don't want to ignore that, right? And then once we have a clear diagnosis of anxiety, we can move on to treatment. Again, lots of overlap here. SSRIs, very good first line medications that we just talked about with depression. SNRIs, benzos for short-term relief. These are controlled, so some may or may not be able to prescribe this. Some may choose not to prescribe this. And then, of course, hydroxyzine, propranolol, great for panic, great for short-term use. And again, this is kind of in the same, this hydroxyzine is in the same drug classes like, oh, what is it? Benadryl. Heva, where are you at? Just say
Antihistamines.
yes, antihistamines, absolutely. So it's a little bit different generation there, but again, not as sedating, but it again it works. And then always, always,
My
always.
favorite go-to. That's a really good one.
Yes, it is. I use it a lot as well. Especially while they're like, you know, if they're kind of building up their SSRIs, you know, a little short-term use there. CBT, cognitive behavioral therapy. Again, patients, we want to address them holistically, making sure that we're putting all this together and not just giving them medicines without a comprehensive treatment plan. Because again, this is very complex here. Lots of different things at play. Again, benzos, I would advise against giving this in primary care for over 2 weeks. If they're going to be on long-term benzodiazepine use, it's not going to be with me. And so I would definitely talk to them about getting in with psych and, you know, are there other options for them? This is, again, not going to be first line, but there are some patients that need this and, you know, it's appropriate. But again, close monitoring and getting it from the appropriate source. And again, you know, potential for tolerance dependent and withdrawal here. So again, definitely want to pay attention here to our considerations, making sure we have the right patient population before we give these. All right, so I'm going to take just a breath and pause here from our lecture because we're going to get into the game here in a minute. But I just want to, as always, invite all of y'all to the exciting things that we have coming up this fall at Archer Review. We have another 3-day live review coming up in November that is going to be with our SurePass and our SurePass people. They're going to have access. Again, this comprehensive package is going to include the QBank, the on-demand, and that live review next month. It's going to be all you need for exam prep with that SurePass guarantee. And then again, if you kind of want to look at some of these other options here, we've got a question bank. We are working it very hard. Over 1,600 questions at this time. There's going to be some video links, some lots of different examples and pictures for you as you go through that. There is a readiness predictor built in that as well. So again, everybody who has not already taken advantage of this, there is a free trial for 7 days for everyone. So, you know, the week or two before your test, if nothing else, sign up for that free trial because that's going to help you to practice those questions. So, you know, to me, that should be a no-brainer. Take advantage of that. And then again, that on-demand package, Heva was really an instrumental part of this one with over 16 hours of content broken down in bite-sized videos videos, easy to take on the go. And again, a lot of our webinars cover superficial stuff, basic things that you need to know for your exams. But if you really are having, wanting to deep dive into content, if maybe there's a topic that you're not real comfortable with, like this is going to help you really just like deep dive and provide that in-depth topic coverage. So again, if you have questions, we have our email set up for you here. You can always connect with us on our Facebook. We put questions of the day on there. Again, all this is free resources for you with this social media stuff. So take advantage. And then again, we have our QR code for you. You can pull this up and look at it a little bit more on the website or by scanning. And of course, as always, we have our mentor sessions and tutoring sessions. So maybe there's something that you're just not real sure about that you want to, talk with me or Heba or Morgan or Rachel about. And, you can book a mentoring or a tutoring session prior to your exam, or maybe you're just getting into the field and you want to make sure that you have everything nailed down. We'd be happy to sit down with you, talk with you, and really just make sure that everything is ready to go so that you're feeling in a really good spot. So again, lots and lots of exciting things coming out here at Archer for you this fall. New stuff, check it out. It's changing all the time, adding to it, and lots of really great stuff. So we would love to assist you in any way. And if you're not sure about what I said, just email us. We'll touch base with you again. All right, it's time for some Q&A, and today is going to be a little bit different. It's going to be name that drug. So we've went through these medications, and there's a lot of them, and so I don't expect you to know every single one of these. But what you're going to do is look at the the example, and then you're going to try to guess which drug it is, and it's like a little matching game. So all right, what is the name of this one? And I'm going to tell you a little bit about the drug. So one of the earliest SSRIs is this one, known for its long half-life and means it stays in the body for longer than some other ones. The benefit of this is that if a dose is missed, then withdrawal does not occur quickly. And these can be useful for patients who might forget to take their medication on time every day. And it also has an indication for OCD, which we didn't talk about today, anxiety and depression. What do you guys think that this medication is? So what you think? I'm going to go ahead and give y'all just a minute to write down in the chats. And again, if you want to take some notes on this, long half-life, that's a good little penguin to remember. Put on your iceberg. So I'll give y'all just a minute. Y'all think about it. All right. And if you said fluoxetine, you're absolutely right. So great job. And this one here, again, it's got that long half-life and it's known as Prozac. So that was a very early SSRI. Okay, so let's take a look at this next one. Prescribed for depression, social anxiety disorder, panic disorder, PTSD. So lots of different indications we can use this one for. It has a higher potential for withdrawal symptoms and if a dose is missed. And then this can also treat seasonal affective disorder and menopausal symptoms, which is a unique feature of this medication. One other thing is weight gain with this one. So a lot of patients, as great as it is, don't love it. But which one do you all think this medication is? All right, y'all are on fire today. Absolutely. Paroxetine or Paxil. So great job. Absolutely. All right, let's take a look at this one. This one here is another widely prescribed SSRI. It has a long half-life as well. This can be used to treat depression, panic disorder, social anxiety disorder, and OCD. Also great for postpartum depression. So think about what might be safe for those breastfeeding moms, right? And think about also has a relatively mild side effect profile, comes in liquid form. It can be beneficial to some of our patients as well, especially those younger patients. And again, safe for pregnant and lactating patients. So what do you guys think this one is? Again, a really good one to keep in our back pocket. So what you thinking? Give you just a minute to take a look. Think about it. Yes, don't think it. You know it. Absolutely. Absolutely. That's right. We are talking about Zoloft for sure. So again, this one is safe for pregnant and breastfeeding moms. So again, this is one that I like to give to those younger people who, could get pregnant. And so something that you definitely want to think about. And I also like sertraline in general because it's one I use a lot, because it also has a huge variety of milligram dosages, so you can really like titrate them in up and down well. And the main thing for this one's like GI side effects, so I think this is like a really good one. But again, it still has a black box warning. You got to be careful with it. All right, this one's used to treat depression, can be just prescribed off label for things like panic disorder, social anxiety disorder, and OCD. And this one here has a unique side effect with QT prolongation on an EKG. So we might want to get a baseline there. And this one here is, again, has a lot of different things that we can consider it for, but again, mainly used for depression. I'll give you just a minute. Which one? Really, several of them can cause this, but this is like our known offender for our QT prolongation. Who wants to take a stab at it? All right. If you said Celexa or citalopram, absolutely. And again, has some off-label indications we can use this for, and it can cause QT prolongation. So something that you want to pay attention to, and make sure that they don't have some sort of cardiac history. All right. And I just gave you the answer on this one on accident. I'm sorry, I did not. I must not have accidentally taken that out. So let's talk about this one for just a minute. Another important one that we give all the time is Lexapro or escitalopram. This is one of the newer SSRIs. Again, the main one is like GI side effects, favorable side effect profile overall. Pretty flexible dosing as well. It can be adjusted easily to meet patient needs. Commonly prescribed for anxiety and depression. And again, together right there is a really good one. Again, this is also safe for pregnancy as well, and has that flexible dosing schedule with low side effects. So again, this is another good one that we use pretty frequently. All right. So I'm sorry, I got my slides out of order. You all know that one. All right, this one here is one of the most frequently prescribed SNRIs. It is used to treat major depressive disorder, generalized anxiety disorder, social anxiety disorder, and panic disorder. So again, lots of different things. It's available in an immediate release and extended release formulation, and it can be helpful to adjust based upon our patient needs. So what y'all thinking here? What y'all thinking for this one? Again, SNRI, so we've already covered our SSRIs. So there's a fewer of these. So you have a more probability of getting it right if you guess. So what you thinking? Give you just a minute. Okay. And this is Effexor, absolutely. So this is a good one because it has that immediate and extended release, and it can help for our patient needs. And again, a lot of different things that we can use it for. So if we start seeing things stacked up, we can use it here. All right, this one here is another SNRI, frequently prescribed, really indicated for major depressive disorder. Now, we talked a little bit earlier about how SNRIs can sometimes be used for those pains, those neuropathies, chronic musculoskeletal things, fibromyalgia, widely prescribed, widely can be used for multiple things together, lower back pain even, and this is a unique one. So what you thinking on this one? You guys are on fire today. Absolutely. You got it. Duloxetine or Cymbalta, again, widely prescribed, widely given, and very effective. Okay, very good. All right, this one here is an active metabolite of venlafaxine and is marketed as an SNRI on its own. It is primarily used for the treatment of major depressive disorder. So, what is that little isolated medication that's a little bit newer than Effexor called? Y'all remember? Okay, it's an active metabolite of venlafaxine. So, it's not venlafaxine. You guys remember? Y'all are doing a great job. So even if you don't get this one, I wouldn't fret. Y'all have done a great job already. All right, this is that one that's Prestique. Um, and this is that active metabolite of Effexor or venlafaxine. And it's commonly used for the treatment of major depressive disorder. So again, not one that we give a whole ton in primary care, but I have a few patients on it and they like it. All right, this one is one of the most widely used tricyclics, TCAs. It's truly one of the most common ones that we see in practice. It's used off-label for chronic pain as well, such as neuropathy, cluster headaches, even migraine prophylaxis, fibromyalgia. Sometimes to help patients sleep even, they use this. Again, if trying to kill two birds with one stone, right? So if they have depression and some of this stuff, it may be a good option for some of these patients. Absolutely. Absolutely. You guys got this. So that's Elavil amitriptyline. Absolutely. I tried to say it all together. So again, depression, but has these off-label uses, very commonly prescribed. And if you're not prescribing it, somebody is out there prescribing it because I see a lot of patients on this medication in practice all the time. All right, this one here, again, closely related to amitriptyline, prescribed for depression, may be off-label for some of those chronic pain conditions, neuropathy, migraine prophylaxis, and a lot of times I see neurology giving this one a lot. Do you guys know what it might be? Again, another SNRI. Or sorry, not SNRI, TCA. Going to confuse you. It's TCA. Absolutely. Absolutely. So this one is a TCA prescribed. It's closely related to amitriptyline, often given for depression and those chronic pain conditions, migraines, and again, neurology. Oftentimes we'll give this one. Okay. All right, this one here inhibits the reuptake of dopamine and norepinephrine. It has minimal effects on serotonin overall. It's prescribed to treat depression, seasonal affective disorder, and also used as a smoking cessation aid and can be used to mitigate sexual dysfunction in patients taking SSRIs. So that should be a hint for you. And what are you thinking? This one also, we want to avoid if your patient has seizures. So thinking about that. And the smoking cessation aid should give it away. You're not sure. Also off-label is binge eating. I've seen it given for that as well. But absolutely, bupropion or Wellbutrin inhibits the reuptake of dopamine and norepinephrine, minimal effects on serotonin, and prescribed for multiple things. Again, try to stack your meds, kill, multiple birds with one stone if you can. All right, this one inhibits serotonin reuptake. It also is prescribed off-label for depression and used at lower doses for sleep aid. Again, I mentioned earlier that we're trying to kind of get away from this one a little bit. Again, avoid with seizures. And this one is that we definitely want to look out for eating disorders. We want to avoid this one with patients with eating disorders. All right. Trazodone, very good. again, inhibits the serotonin reuptake, antagonizes certain serotonin receptors, and we see it again for depression, sleep, and avoid it with eating disorders and seizures. So very good, very good. All right, you guys, y'all have done a great job today. Y'all blew my socks off with those meds. So keep up the good work. I think you guys that are getting into practice aren't going to be nearly as intimidated as I was when I started in mine. But that is good. Keep up studying on those because you will see some of the questions related to that on the boards. We are so excited to meet you where you're at. Let us know how we can be of assistance to you. We're here. We're cheering you on. Reach out. I've got it here for you again if you missed the link earlier, and we're happy to work with you in whatever way that you need. And yes, there is a way to access the recording. You can look on Facebook. It is on there as well. And so on our Facebook page, we're live on there right now, actually. So if you're on Facebook joining us, hello to you. And again, if you need to study on this a little bit more, we'd be happy to sit down with you, take a little bit deeper dive, talk through it again. So email us your questions, connect with us on social media. We're going to plan to see you next week. I think, or I'll plan to see you all in a couple of weeks, but I think Heba and Morgan still have some stuff this week. So again, lots of exciting things going on at Archer coming up. So we'll stick around for just a minute or two if y'all have certain questions that we can help you with. Otherwise, we'll see you soon. Okay, so we just put the FNP SurePass link in the chats for you, Heba did. So there is your direct link for that if you for those who had specific questions about that. So check out the chat real quick.